So, good morning, good evening, and welcome. We're really happy to have you joining in our session today. And today's session is a really fascinating one. We're looking at what are the ways that we can really increase participation, equity, and policy change when we're working with disadvantaged young people. We've got a really exciting spread of case studies to look at, and from really diverse parts of the globe, which is one of the wonderful things about HSR 2020, that we've got such a great representation from all over. So we've got case studies from Cambodia and Zambia and Sweden, and we'll be going through and looking at what is it that we can use in our research and in the ways that we work that will increase, gives the maximum opportunity for participation and equity. So we're looking at four different settings. The setting in India has focused on young people living in informal urban communities. The setting in Cambodia is among young men in prison. Then in Sweden, we're looking at remote rural areas, so people disadvantaged more by geography than by social structures. And then in Zambia, it's rural communities with other forms of socioeconomic disadvantage. And so what we're really hoping that each of us can take from this session today is what is it that we can use, and what are ways that we can really use our ways of researching to bring transformation. So using the idea that research is not an impassive objective observer, but something that's engaged and that can make change as part of what we do. So we're really excited to have this session. Just as a kind of background, all of us have recently completed PhD studies with the University of Umeå in northern Sweden. The Global Health and Epidemiology department there is really engaged and supportive for people working in low and middle income countries, but also has a really strong focus on increasing equity in places like Sweden also. So we're hoping that this gives you ideas of how to go about research and use research as a tool for transformation. Just as an overview on the format today, we'll be swinging into the four presentations, and they're going to be running back to back. So we're starting off with the Zambian presentation with Chama. Then we have Putti, who I'll also introduce, who is going to be leading the Cambodian. Then I myself will present the Indian team's work, and then Frida in Sweden will complete. And then we have Dr. Bumi, who's a team leader with Caritas and who's also a colleague we've all worked with, who's going to just give some broader observations. And then we've allowed about half an hour or so for questions and answers, and also keen to hear discussion and see what's coming in. All of the discussion is going to be on the on-air event platform. So I really want you to keep sending in questions and answers. We're all going to be looking at those and really keen to keep those coming in. So please, during the sessions, keep adding in your questions. We're really excited to see what your ways of engaging, because it's often a really great opportunity for learning. So please do keep sending in your questions as they come, and we'll have a moderated session, the final 25 minutes or so of today's session, to kind of work through things. So that's a little overview on the session, and we're really excited to hear and see what you've got to do. So I'm going to introduce Chama, who is our first speaker. Chama is the study manager at the Center for Infectious Diseases and Research in Zambia, and her work has been focusing on adolescence and sexual and reproductive health. She's a doctoral student at Umeå University, and her PhD is called Community-Based Reproductive and Health System for Adolescents in Zambia, and she's used a realist evaluation approach. So I'm handing over to Chama now. She'll go through her presentation, and we're looking forward to hearing from you, Chama. So welcome, and welcome everyone else as you join in our session today, which is, I think, going to be a really exciting and interesting way to look at participation, equity and policy, and how we influence those in the ways that we research. So we're looking at really big lens on methodology as well as what we learned. Okay, welcome Chama. We're looking forward to hearing from you.
All right, thank you, Karen, and thank you everyone for joining us today. And as Karen said, I'm quickly going to take you through one of the studies that we conducted in Zambia in rural areas, and also this focused on how we ensured that the girls or adolescents participated in our study. Then at the end, I'm going to share some of the lessons that we learned as we conducted this study. So our study combined photo elicitations and discourse analysis to examine adolescent sexuality in rural Zambia, as I had mentioned. And as we are all aware, sexual reproductive health and rights, attaining this remains a challenge in many countries. And this is often a neglected issue, and more so in sub-Saharan Africa, where contextual factors such as religion and traditions affect adolescents, and also political factors, political systems are weak. So we find that these factors tend to shape how adolescents negotiate, adopt, or even resist sexual reproductive interventions that are offered to them. We also, from literature, know that for such interventions to work, it is better to adopt the holistic approach, and this should recognize the digital and immediate factors that affect adolescents, as well as, more importantly, the cultural scripts that shape how young people understand and experience sex, as well as reproduction and other sexual reproductive health and rights programs that are offered to them. So our study mainly aimed to understand how or analyze discourses on adolescent sexuality and sexual health, and the consequences of these discourses for adolescents to exercise their sexual and reproductive health and rights in rural Zambia. So we nested this study in the broader research, and this research is called a research initiative to support the empowerment of girls. This study, in which we nested the smaller study that I'm presenting about, is a 3-arm randomized controlled trial, which was conducted in 150 rural schools and was aimed at reducing adolescent pregnancies and early marriages. So to tell you a little bit about this broader study is that it had the control arm, the community arm, as well as the economic arm. The full intervention arm is what I'm referring to as the community arm. And in this arm, we had teachers working together with community health workers, and they coordinated community meetings with parents and community members to support and promote social norms towards adolescent sexual reproductive health. Within the schools, they also established or strengthened the existing clubs in which they offered adolescents lessons or knowledge to improve their sexual reproductive health and rights knowledge, as well as the pupils who were in these schools. They received school fees support, annual financial support going to their parents, and also a monthly support for them to use to buy the needs that they had at school. So we nested this study in this full intervention arm, which are these interventions that I've described. And we purposively selected 4 schools in this community component arm, or the full intervention arm, where we collected data. And this is the data that I'll be talking about in this study. So our study design was mainly using photo elicitation interviews, in-depth interviews, and focus group discussions. I'll describe this a little bit more in the next slide. So we first started by what we call the preparatory phase. And in this one, we identified firstly the 4 schools where we wanted to work. We wanted to get the 4 schools based on schools that could offer us diversity of views from the adolescents. So that meant schools that were closer to town, as well as schools that were very far from town. And in each of the schools, we selected 6 to 7 adolescents, which gave us a total of 25 adolescents across all the schools. And then we trained them on how to use photographs. We also, during the train, discussed the ethics related to taking of pictures. And then we asked them to go, we gave them the cameras, and we asked them to go and take pictures that represented their views on sexuality, as well as anything that would help us to understand. So then during the process, they started taking pictures, which is in step 2. And during this process, we kept interacting with them, looking at the pictures that they took, sitting down with them to select pictures they wanted to share, as well as narrating why they had taken each of the pictures. This was then followed by in-depth interviews with each of the adolescents. And later we had a focus group discussion in each of the schools to get group views on what their thoughts were on adolescent sexuality, as well as the consequences of these discourses that they brought in terms of accessing sexual reproductive health services. And after this, then we went into data analysis. And during data analysis, we first linked the pictures to the transcribed interviews, focusing mainly on how the participants had narrated the photographs. And then we used discourse analysis to consolidate the findings, and mainly focusing on interpretative repertoires. So we focused on what was coming from the pictures, including the statements as they were highlighted the participants. So as I said earlier on, the pictures were interpreted by the participants themselves. So some of the things that came up from our discussion were summarized in 2-3 interpretative repertoires, and I'll go a little bit further to share on each one of them. But in summary, so this was the first repertoire that we termed as sex is not for mature people. The second one was gender disrespectful or respective behavior. And then the third one was acquiring and using knowledge on comprehensive or sexuality. So the first repertoire, in this repertoire, young people positioned themselves as immature or too young to engage in sex. And this really had serious consequences on how they adopt sexual reproductive health interventions, as they couldn't seek certain services such as contraceptives and condoms. I have put here some quotes from 2 adolescents who participated in this study. One of them said, "You should check your age before you go to the health facility to ask for condoms and contraceptives." Generally, there was a feeling that if you go without checking your age and the nurse or the health in charge finds that you are young, then they will shout at you, they'll turn you back. And then others seriously believed that, as one said, we are young and not mature. Our parents look after our sexual health. Our parents teach us what is bad and what is good. This meant that they were not making any effort to make any decisions about their sexual reproductive health and rights. The second repertoire, which is gender disrespectful and respective behaviors, we found that what was considered disrespectful or what was considered respectful was influenced by gender. And this was mainly more really defined for girls than for boys. So for girls who were considered to be sexually active or had been pregnant before, those were considered as bad girls. And the girls who seemed to be abstaining were considered as good girls. And this was very distinct, but that was not distinct among the men. In fact, among men, the discussion about respectful or disrespectful behaviors was mainly centered around them paying attention in school. As one of the participants said when they shared this picture of a girl wearing a miniskirt, saying, if you sleep with men, you will become like her, wearing miniskirts, looking for boys. You will stop obeying parents just like her. She has lost her respect. Then the third one was acquiring knowledge on sexuality. And in this discussion, the adolescents conflicted between having knowledge and applying knowledge. So at this, in this repertoire, they considered individuals who were sexually active or engaging in sex or even pregnant as individuals who didn't have knowledge. So they used, sometimes someone says, you know, that those people who are pregnant, it's not their fault, it's actually lack of understanding. So they really emphasized that this was this. And the other thing that came out was some participants recognizing that lack of knowledge was not everything, because adolescents were also faced with other factors such as poverty. And but even then, it wasn't still acceptable for any adolescents to engage in sex or even to seek sexual reproductive health. For some participants, they referred to such girls as some girls are just desperate for money. They use terms such as she's looking for money, she wants money, she's possessed with money, she's desperate with money, which was really stigmatizing in a way. So some of the lessons that we learned while conducting this study is that when we had an encounter with them more than once, that is through the photos that they were taking, the girls were able to open up and they were able to discuss a little bit more in the in-depth interviews as well as the focus group discussion. And they were able to bring up the lessons that they had learned even while participating in the RISE projects that I talked about. And then we also saw that participants felt more empowered by giving them cameras, and also they were more confident discussing their photos, and this made our transition easier when we went to discussing anything in the in-depth interviews as well as the focus group discussions. We had some challenges where participants at first couldn't understand what types of pictures to take, but we made them comfortable by re-explaining to them, as well as making sure that they understood that whatever pictures they wanted to get was their choice. And we would also give them another choice to share which pictures they wanted to share when they came back to us. The other challenge was that some participants also wanted to get pictures with classmates, pictures of the community, pictures with their family, but it was challenging obtaining consent from such individuals, especially if they were not participating in the study, but captured in the pictures. So we did encourage our participants to only capture people who we could easily get consent from, or they were able to capture them without any identifying features. Then when we were doing this, we found that the presence of the teacher, because these FGDs and in-depth interviews were conducted in schools, really affected how the participants opened up. So we had from the onset asked the teachers to be away from our discussions and made sure that we emphasized that anything that we discussed was confidential and their discussions would be protected. So we spent a lot of time trying to emphasize that they were safe to open up and share. And so these are some of the lessons that we learned in terms of engaging adolescents so that they can bring out what they had. You remember that this was done in a setting where these adolescents had participated in a sexual reproductive health intervention RISE, but even then we still had to take an effort for them to open up through the photo elicitation interviews and the other activities that we did. I think I will end here. This study was funded by the Swedish Research Council, and we also thank everyone who participated in this interview. I'll just share at the end some of the references that we had used in this study. Thank you very much. I'll hand over to Karen.
Well, thanks a lot, Shama. That was a really interesting start, and it was really useful to think about what are the lessons that you learned about how to get the most, I guess, the most sort of true data by building relationships beforehand, that we're having that familiarity, giving you a higher level of engagement and people sharing at a more honest level. So we won't stop for long now. We have next, we have Puti, who is the Training and Research Coordinator at the Center for Child and Adolescent Mental Health in Cambodia. He leads a team which is doing operational research on psychological interventions for women who have been trafficked and siblings of children with neurodevelopmental disorders. And he's also a doctoral student in Umeå, and this particular focus of his has been using life skills interventions to promote mental health situations. So we're really happy to have Putti with us. Welcome, Putti, and we're looking forward to hearing what you've got to say. Thank you. So Putti, you can use the go up to the view slide button. Yep, you're there. Great.
Thank you, Karin. Good afternoon and greeting from Cambodia. I'm going to talk about the research in Cambodia on giving voice to young prisoners, a mixed method study on mental health, the prison health system. I'm going to talk about the background, research questions and methodologies, outcomes, strategies and proposed action, as well as the challenges and opportunities during our research. Cambodia is a post-conflict setting. We have a history of more than 3 decades of civil war, and many people die during the time. At least 1.7 people die because of starvation, overwork, and medical neglect. And most of the children became child soldiers. The research showed that armed conflicts and some natural resources are more likely to happen in the poor setting like in Cambodia. And those children and young people in that setting are at risk for child and adolescent mental disorder because of the war, conflict, cumulative trauma, PTSD, suicide behavior in this kind of setting. As you see in this picture, Cambodia is located in Southeast Asia with a total of 28 prisons and 36,600 prisoners. The data was in 2019. And we found 30% of the total inmates are below 25 years. To our base knowledge, we found the study on prison mental health from high-income countries, especially from Europe or from the US. Still, there are some studies from low-income countries, but none of them from Cambodia. And our research is the first ever study in this poor setting country. We see in Cambodia prison, there is no mental health services, and mental health problems have been neglected for many years. So in order to give the chance for the young prisoner to participate or to express their mental health needs, we as a research team have estimate or have formed 2 types of research objectives. First one is to estimate the mental health problems among young prisoners. Young prisoner here, we refer to those between 15 to 24 years. And we also
sorry, just quickly interrupting, the slides aren't advancing. So if you look at the presentation we're seeing on the screen is just stuck on the first slide. So if possible, go to the view screen button and do the slide advancing. Sorry to interrupt you.
Sorry. Maybe I can see again.
Okay, good. And can that advance down to the next one?
Did you see my slide now?
Yeah, now it's advancing. Thanks. That's good.
Okay, sorry. So we also conducted a focus group discussion with those young prisoners to understand their views on mental health and to give them the opportunity to give voice to express their needs in the prison setting. So in order to achieve these research questions, we conduct both quantitative and a qualitative study. In our quantitative study, we conduct a cross-sectional study with 572 young prisoners in 4 different prisons, and we use JUTSE report. This instrument has been used in Cambodia before and have been translated into our national language, and it was used in a Cambodian secondary school study. In our qualitative study, we conducted 6 focus group discussions with the same age group of young prisoners, 3 female groups and 3 male groups. Let's move to the outcome of our study. The prevalence of mental health problem. We found roughly between 40 to 50% of our participated young prisoners suffer from at least one type of mental health problem. Anxiety, depression is the most common one, accounted for 52%, and the rest, for example, social problem, somatic complaint, or rule-breaking behavior are between 40 to 50%. We see the young prisoner experience a lot more mental health problem compared to the adolescent in the general population. In WHO in 2020, in their website revealed that adolescents might suffer from 10 to 20%. I mean, adolescent in the general population. But what we found among the young prisoner between 40 to 50%. So it's more than double compared to the general population. When we look at our qualitative study, we come up with 4 different themes. The first one, young prisoner express unmet physical and psychological needs. So almost all of them express that their basic physical needs are not met. For example, food or place to sleep, and as well as the emotional support is not there. Yeah. And the second one, the prison mates and family are the social and emotional support while incarcerated. So they express that their friends in the prison and their relatives who are living outside the prison are the main source of support, both social and emotional. And when we come up with the ways to improve their mental health in the prison setting, they express that participatory activity, for example, like exercise, gardening, sporting, and so on, are the main activities that can help them to improve their mental health. And nobody talk about the prison authority or the prison official that can help them to improve their mental health problem. So we found them feel disempowered, marginalized, due to a lack of confidence on the ability of the prison authority to integrate prison mental health system, to offer them the mental health care in the prison setting. So after we found our outcome in our mixed method study, we also have the strategies and the proposed action to go forward as well. Our strategies to integrate prison mental health system, we also we already conducted a qualitative study with the prison official. So in order to include mental health services, if we just study with the young prisoner, it might not possible. So we also conduct a focus group discussion with the prison authority to explore their view on mental health and to find the possibility and also the modes to integrate mental health care in the prison setting. So in order to advocate with them to integrate mental health care, we also plan to provide training and workshops for the prison officials on mental health. So we expect them to understand, to raise their awareness on mental health. Maybe they are able to identify the prisoner with mental health problem, and they might be able to provide some basic mental health care. And if needed, we also help them to refer to other agencies. So mapping the referral networks with the prison official is another strategy. In our action plan to bring health equity and inclusion in the prison setting in Cambodia, we also plan to conduct a national level consultative workshop with the planners and policy makers. So at 3 different levels, we conduct the qualitative study with the young prisoner, with the prison official, and now we move to the prison authority or the top management of the prison authority to advocate with them to bring changes to their prison health system. And by doing so, we also have to share our outcomes of the mixed method study, and we also help them to develop an implementation plan, which consider as an evidence-based intervention program. We also try to explore the opportunity to help young prisoners to express their mental health needs in the public forums. So we discussed with them, with the prison authority, to find the possibility maybe to organize a World Mental Health Day somehow in the prison to allow the prisoner to express their needs in the public forum. In our study, we also faced some challenges. First one is about the literacy level. Around 50% of our participated young prisoners from a very low level of education. Most of them never attended school or at primary school level. So lack of literacy among those young prisoners deprives them of the opportunity to raise their voice and compromise their level of participation. We found in the focus group that they don't trust or they don't feel confident on the prison authority to improve mental health system. So this lack of confidence also make us face some challenges as well. Prison health system is not part of the Ministry of Health. And so we found a lack of coordination between the prison health system and the general health system. This is also another challenge. So not only challenges, but we also find some opportunity as well. We consider our mixed method study is a main tool to raise the awareness and to bring changes in the prison health system in Cambodia. And we also consider this is as a chance to give voice to the young prisoners to be heard. And we also plan an intervention program that's specific to each prison setting as well. Thank you very much.
Thank you very much, Putti, and really interesting to look at the ways you were using and engaging with policymakers as you were progressing on that. So the next case study that we're looking at is set in India, and I'm going to present that work. I'm Karen Matthias, and I'm a public health physician. I've been working with a team in India with a mix of research and practice, employed by a non-profit organization in India, the Emmanuel Hospital Association. And so I'm going to present work that we've been doing, which was trying to use participatory methodologies as we were exploring issues around gender relations in India. So I'll just get my screen up. Okay, so this study was one that we started doing as sort of nested within a larger study, and it was considering what happens when we collect data using with young people as the data collectors, and could it contribute to a deeper understanding of the context. We were particularly interested in doing a study that was considering a realist study, which was similar methodology to what Shama used to understand the context and the mechanisms and the outcomes that were achieved. And so we were keen to say what could be benefiting our understanding when young people are collecting data rather than having researchers from outside. So the organization who I work for and is I'm the project director is Burans, and it's an organization that works with communities for mental health, and three main strategies of working around co-design, strengthening community and public health systems, and research. We're located in the north of India, in Uttarakhand state. It's a state with 10 million people, and this study is set in our Dehradun setting, which is the capital city and a really beautiful valley 300 kilometers north of Delhi. The reason we were focusing on gender relations with a focus on young people is there are really huge inequities related to gender in India. It's 132nd in the World Gender Gap Report. Right across India, but particularly in the northern states, there's a huge difference in the literacy rates. And there's also sort of, I guess, the terminations of pregnancies focus on females, so that there's a quite disproportionate ratio of males to females. So this research, the bigger picture was trying to understand the changing gender relations for young men and young women who had been part of a youth resilience intervention. And so we were to understand gender relations, we felt that's quite a personal thing to discuss how that works among peers. And we thought maybe we can get better quality data using peer data collection. The intervention has a strong empowering focus, and we did most of the data collection at the completion of this 18-week youth resilience and mental health intervention. This shows some of the pictures. One of the parts of the intervention is encouraging young people to identify an issue in the community and then to speak about it. And so you can see that happening here. Young women doing a march, and then also some young men on different issues. The way we recruited the participants was they were all members who were part of our randomized controlled trial. We had a really high participation rate. The trial had 520 young people, but the workshops that we used for data collection were with just 24 young people. So the main data collection was about 4 or 5 participatory researchers, workshops, and we'd set the research aims by the research team, which included youth peer facilitators, but this wasn't fully co-produced research because we had set the objectives prior to inviting the young people to join us. We did a training around communication skills, group facilitation, and discussed what we hoped would be the format and the ways of collecting data. And then this group of young people arrived at a setting and rotated around activities that were facilitated by peers. We used quite a range of really active approaches. So we had a big whiteboard and people drawing pictures on what are the characteristics of girls versus boys in their community. We had another area that was people having to write, what's something that I like about being a girl or being a boy? And in this setting, and at this age, there wasn't anyone with a third gender or gender diverse groups. We had another place where people were able to do role plays. What would it be like if a young man became his sister for a week? What would change about his life? So just trying to understand how does it work being male and female. We had some, it was following on from what Shama suggested, we found these were young people who we already had really good relationships with. We had done 18 weeks of meetings together. This was the Youth Day celebration last year. We had this great activity. Each team was given 30 balloons and a roll of sellotape, and the winner was the team who built the biggest tower. So there was lots of sort of hands-on colour and fun and noise. It was a lot more fun than the average in-depth interview. So this was one format that we used, and we had an observer, Somesh, who many people in the team here know. So imagine that a boy became a girl for 1 week. What would be different? And so the young women had to discuss what would change. He would have to get up early, do jobs like make breakfast, mend clothes, and follow his parents' instructions instead of doing what he wanted. He would find it so terrible. So certainly it wasn't a big advertisement for being a daughter rather than a son. We then had these like really engaged groups. So you can see this group of young men, they had to write down, what is it that you like about being a boy, writing phrases. And it's not shown in this picture, but a lot of it was about the freedom that they had playing sport, riding a bike, earning money. Whereas a lot of young women in India have really restricted freedom of movement. And then we also had doing role plays, what is challenging about being a boy. A really big theme that came through is that we're expected to earn money, but it's really hard to get a job. And a lot of these young men had not completed primary school or had quite low literacy. So it was difficult to get a job, but this sort of breadwinner expectation. This was after we'd run all the workshops, and we still had some data gaps on our research questions. And so we reverted to focus group discussions. What was different for you growing up versus your father growing up? And they're still really interested in engaged discussions. And I'll talk briefly about why we did end up with data gaps. So starting off with what went well in using this participatory approach, we had some really interesting discussions where we felt that because young people were eliciting the information, they could talk about like, well, how did you convince your mother to let you come to the picnic today? And well, my mum it's so unfair. My brother goes where he wants, but I have to ask permission for everything. And so there was a kind of like, oh, it's the same for you, it's the same for me, and that kind of interaction. We also found that they were, like the recordings that we had, they were actually quite hard to get the data out of because there was everyone talking on top of each other, but it was quite interactive. And there was much less censoring of, so there was a lot more swearing, there was more joking and teasing than when you have a focus group discussion with a researcher. Some of the challenges, I just want to acknowledge here that if you want to play cricket, even in very difficult circumstances, people find a way. And so some of the challenges were things like, because the young people were in a new setting where they'd come to a new area, they were all quite distracted and excited and chatting. And it was more like this is a picnic or an outing, and they weren't really focusing on the questions. So we felt like another time we would probably have some other workshops that weren't about data collection in that location, so that they were just very excited and giggly. Some of the young people who are collecting data just hadn't had enough experience at collecting data, and so they're quite embarrassed. The recordings weren't great quality because there was too many people talking at once, and we had several groups in a spread out area, but it still wasn't a great recording. And then probably the thing that was most disappointing with the data collection was that there was this quite big group think. So I remember one of the groups I sat in on, what do you wish that you could do differently for your children that hasn't been possible for you? So thinking ahead. And one young woman said, no, everything in my life is good. It is important to follow what your parents say. And then everyone in the group said, no, I don't want to change anything. I just want to do what my parents say. And so it was very kind of conforming opinions. So there were challenges. The groups had a great time. The young people had a great time. And I think we did get some useful data, but it probably wasn't as useful as we would have liked. And these are a few quick questions before I finish up. We felt that we should have done more training for the young people as data collectors. They needed to have just facilitated groups, and there were some people who were really noisy, particularly the young men. One of our mistakes was because we had got permission for the young people to leave their urban slum area, we thought, oh, well, let's do data collection. And then they were wanting to go on a picnic, and because they had permission to go out, they'd been promised a picnic afterwards. But this was actually a very bad idea because they were all so excited about going on a picnic. They didn't answer our questions very well. So we wouldn't combine those again. We needed to get good recordings. We needed better separation of rooms. And we had a couple of sessions we thought we'd try doing the workshop with girls and boys together, but because it's not that culturally normal to have spare time outside of school with girls and boys mixed together, they were all silly and giggling and weren't in that much of a frame of mind to share what they were really thinking. So I would say it was a great experiment, and we need to learn more about how to do it. I really like this picture because it shows that can-do attitude. If I want to have chai in my student hostel, I'll turn the iron upside down and I'll make chai. And I guess that's really a bit of the message. There's a word in Hindi, jugaad, means, making do with adverse circumstances, which I guess is a lot of the experience for many of us through the COVID era. So messages, give it a go. The multiple modalities gave us some really textured data. There's lots of potential, but it does need some good thinking to get good quality data. And I'm really hoping that we've got some questions and answers running in on the question and answers. I'll just go to look at the slideshow, but thank you. And I'll stop my slide sharing there. So we're now going to the final presenter, and that is Frida. Frida is Frida Johnson has completed her PhD, and she mostly focuses on ways that access to healthcare and social care and experiences of health can be improved for marginalized young people living on the edges in rural northern Sweden. So we're really happy to have Frida with us. Welcome, Frida. And we're looking forward to hearing what you've got to say. So over to you.
Thank you, Karen. I will share my screen. Is that okay?
Yeah, we can see that fine.
You can see that fine. Perfect. Okay, so I'm going to present a concept mapping study that me and my colleagues conducted in the northern part of Sweden, which is popularly known as Norrland, and focusing specifically on the rural peripheries in that area, which are located more in the inland of northern Sweden. And here, our aim or our focus was to explore collective imaginaries of caring landscapes for rural youth. And in particular, following Chuck Smith, who you see this, one of the papers presented here, who in 2018 encourages us as rural scholars to move beyond the sustainability of peripheral communities to instead focus on the underpinnings of a good countryside. So following this, his discussions in that paper, we used the approach, Levitas approach of utopia as method, combined with the concept that we've been using in a previous paper, the framework landscapes of care, to then explore collective imaginaries of caring landscapes, specifically then in relation to rural youth. And this is the most central part, while focusing specifically on what such landscapes ideally should look like, and also how various more concrete strategies could help or be implemented to realize this visionary views. And overall, this research is a response to a general lack of youth perspectives when it comes to discussions about access to and experiences of health and social services in rural areas, especially in the global north. And in this regard, our research contributes to the literature by positioning young people at the center of this debate, but also by taking a more holistic approach to this topic than is usually the case. And this we do by incorporating or building on the idea that a good life in decent or proper health for rural youth might actually go beyond just the availability or the quality of services to include broader notions of care, which then involve experiences that are bound up in more dynamic and multi-layered landscapes. And also, rather than just exploring what characterizes a landscape or landscapes of care, which you see we did in an earlier paper, in this follow-up research, we're more interested in what can actually be done and how to ensure that landscapes are indeed caring and then not a source of despair, which was a finding in this earlier paper for young people in peripheral northern Sweden. And to facilitate the scope of this study, we used concept mapping as the overarching methodology. And by giving the participants an opportunity to visualize ideas and discuss an issue that they have a mutual interest in, and then contribute knowledge that can be valuable to develop culturally tailored or community-based health interventions, this approach has recently been considered useful to increase community involvement in research. And also, since this methodology allows participants to identify answers to a prompt or a focused question that is often posed in a visionary way, where you aim for advancements or improvements, this approach also has the potential to function as a catalyst for imagining alternative scenarios or futures. And in its sort of more traditional or standard format, concept mapping involves the generation and the integration of both qualitative and quantitative data by participants in sequential steps. And the process usually begins with a generation of ideas, a brainstorming, where you should try to come up with as many answers as you want to this prompt question. And after you have brainstormed and received a list of, you usually then end up with a list of ideas where you have to remove duplicates and things like that. You allow participants then to structure these ideas by either first sorting them into different piles according to in a way that the participants feel is meaningful for them. And if they want, they can put labels on these different clusters. And then they, after sorting them, they can rate the different strategies. And then you can, as a researcher, you can decide on what sort of scale you want them to rate them. And we decided that we wanted our participants to rate according to feasibility and importance on a Likert point scale from 1 to 5 usually. And then after you brainstorm the ideas and you've had the participants sort and rate the ideas, you end up visualizing these ideas by developing conceptual maps, and that you do through multivariate statistical methods. And compared to this more traditional or standard stepwise procedure, we took a little bit a different approach and modified the concept mapping methodology in well, 2 major ways. First, as researchers, we took a more active role in the process of analyzing data. And in particular, rather than just what we felt would be just supporting the participants in visualizing and reporting their ideas, if the end product is then this concept map, which is usually the end product in a concept mapping study, we saw ourselves more as actively co-producing the results in dialogue with the participants. And secondly, we placed the strongest emphasis on the qualitative aspects of the process. And this meant, as I just said, we did not build our results on the final map that would have been based on multivariate statistical methods, but on findings from 3 different phases of data collection and analysis. In short, this first phase was actually a secondary analysis where we reanalyzed data that we had been collecting for, it was all part of the same research project, but the data was collected for another study, the study that I mentioned about exploring what characterizes landscapes of care. So we had a lot of data there. We had 5 rural communities, doing focus group discussions and individual interviews we did 16 individual, in this data set, we had 16 individual interviews and 26 focus group discussions with professionals and young people that live in 5 rural municipalities in Norrland. And since we had this rich data, and when we did this data collection, we also asked the participants to give suggestions on how to improve the social situation and the health situation in their communities. So we felt that there might be possibilities to to also find sort of collective imaginaries in this data set. So we reanalyzed it with these glasses on, which were, we actually find a lot of useful and interesting information. So after we, and here you see also the participants. In the first phase, we had 63 youth participating and 44 professionals. And the professionals were working in different areas related either to youth or health services or social services. And during the second phase, we held a one-day participatory workshop where we were 31 people in total, 6 young people and 25 professionals, policymakers that came from various parts of Norrland, participated, and they were asked to envision an ideal caring landscape and to think of possible answers then to this prompt statement. In order to create opportunities for rural youth to live a good life in decent health, the strategies or efforts needed are, and then they should respond to this, this question or this statement. So we have this for the participatory workshop, and as you see in the pictures, we had, which was divided into different parts, but the focus was mainly to get these different actors together and to have them discuss together in different groups. So a brainstorming session was mainly the focus of this workshop. And then in the last phase, all of the 31 workshop participants and then an additional 11 who had not been able to attend but wanted to be engaged in the research was invited to conduct the sorting activity. This is about grouping the statements that had then been identified in the workshop. They were then asked to sort these strategies in a way that for them was meaningful. And this was done individually in front of their own computer in their own home using the group wisdom software. And in this way, we were able to land in a more traditional concept map, as you see here. So strategies that the participants have more frequently grouped together will end up on this point map, and then you get this nice figure. And so based on the findings from these 3 phases of data collection and analysis, we ended up developing the findings and discussing them through also 3 conceptual areas. We did not look for it. 3 is a magic number, appears to be here, but it wasn't intentional. It ended up being that way. We developed the findings were discussed through 3 conceptual areas, which then indicated that caring landscapes should provide services related to healthcare, education, leisure activities, for example, housing and employment, in a sustainable and in a coordinated way to ensure that they are responsive to young people's both wishes and needs. And then that caring landscapes should be organized around the values of safety, equity, and youth participation to ensure that all young people, irrespective of social class, health status, gender, ethnicity, or race, sexual identity, or functional abilities, are able to feel a sense of security and belonging in their community while simultaneously having the power and opportunity to influence aspects of their life that they feel matter to them. And the last conceptual area was that caring landscapes should rework the metro-centeredness that is characterizing Sweden. And in order to address the both structural and discursive aspects that largely disfavor peripheral or rural communities, while strongly affecting their ability to care for, with, and about rural youth. So what in this process did we think worked for us? In the research, from the beginning, a strong focus was placed on promoting equity. For example, we focused on a group the rural youth, who so far has received quite little attention both in youth research and in rural research. And we acknowledged and also tried to account for the fact that this group is highly heterogeneous in terms of, yes, I said, just gender, ethnic background, sexuality, class, age, functionality. And the equity component also emerged from the fact that our aim was to be action oriented and try to generate knowledge that can be useful to create opportunities for rural youth to live a good life in decent health within landscapes that care for them, that care with them, and that care about them. But rather than this being like a direct consequence of, or like inherent in some way in the methodology, concept mapping, I think it was mainly a result of efforts that we took and decisions that we made when we developed the research questions, when we decided on how we approached the potential participants. So the equity component doesn't necessarily just come from just doing a concept mapping study in itself. And some challenges and lessons for us. Well, concept mapping may indeed allow for and be a way to increase community involvement in research. But when it comes to promoting youth participation, we found that it was, and as you also saw in the study design, while we were able to engage quite a lot of youth in the first phase, and we were also able to include quite a diverse group of young people, both in terms of age and in terms of sexuality and in terms of ethnic background and socioeconomic position, etc. The youth who participated in the workshop and the youth who then also were finalized the concept mapping was quite few, which was very disappointing. So the problem with it might not be just in the concept mapping, and even though we might think that young people will be sort of doing a concept mapping study, and especially maybe online, and when we're doing in rural areas where be able to do research sort of semi-remotely, where they can sit at home and do things in front of their computer, and then we get the results, it was still quite hard to get them engaged, which for the future we need to think about how to really get young people interested in the research and engaged. And also, even though we had a focus from the beginning that we wanted to prioritize young people's perceptions and experiences, we found it quite difficult to meet this sort of the expectations that we had when young people's ideas were expressed together with adults or professionals. For example, in the workshop, they were both young people and adults there, and yeah, there was some sort of power dynamics going on there that yeah, first of all, it was harder for young people to come through with their ideas, even though we really tried to give them space and give them a room and have like an open climate. So in the future, it might be, we would probably do separate workshops, one for youth and maybe even different types of subgroups of youth, and then one for professionals. And in terms of policy change, even though concept mapping is also said to be contributing, you're asking the participants to come up with ideas on how to improve a certain area here, make landscapes more caring. But it's also, is that enough in order to really contribute policy change? Maybe the aim is a little bit too ambitious, and also we're struggling now with how to communicate this information, because even though it starts from the participant, it has gone through the research or academic sort of way of analyzing, so it has a certain language to it and things like that. And are we then going to sort of transition it back to making it more available and accessible? Yeah. Okay. Thank you, Karen.
Great. Thanks very much, Frida. And really, I think for all of the studies, really interesting to get the challenges, because often when things don't go to plan that we learn for the future. So I'm going to welcome now Dr. Bhumi Kumar, who is a psychiatrist working in Cambodia for many years. And I just thought it'd be really great to get, as someone working for many years in youth mental health, but in youth health, to get Dr. Bhumi's perspectives. And meantime, we're not getting many questions on the Q&A function. So if you look at your on-air events platform, send those in, and we can, and people who presented, please just type your responses. There's some that are named for different people. Welcome, Dr. Bhumi. We're looking forward to what you've got to share.
Thank you, Karen. It's a wonderful presentation, wonderful group of wide landscapes you brought in, from very high income country to middle and low income countries, right from Sweden and India, Cambodia and Zambia. And what a quite variety of young people and challenges. And two of the first presenters from Zambia and Cambodia, they were focused their studies on an institutional setting, meaning in school setting and prison setting, where the rest of the other two from India and Sweden have focused on community setting, and the India from the urban setting, and from Sweden, the rural setting. And all the four presenters very nicely brought in the methodological issue, different methodologies, they used it to bring out the different challenges. And both the Zambia and the India one brings up the gender issues into the focus. And in the context of the current pandemic, the whole focus, all the four presenters brought in of a youth-based and youth participatory research in health systems for policy changes is become very poignant, because a lot of the rising incidence of COVID-19, unfortunately, is being blamed on young people in Europe and elsewhere in North America. There is a kind of maybe system failure, in the sense we have not communicated as health policymakers, health planners. We have not reached the young people with the right methods to convey messages, perhaps. In that context, all the four presenters bring in the strategies and methods to involve young people in their own research methods and how they can influence the policy issues. There is a lesson learned here. Thank you for all the four presenters. And other than typing, if there is enough time, you can come back, click on, and if you'd like to answer the question, I don't know, Karen, if there is any time for that. And my question would be to both the Swedish and the Indian presenters. Unlike the other issues in the rural, from Cambodia and Sweden, unlike the other two, you did not touch upon gender issues. Were there gender issues in the prison setting in Cambodia and in Sweden among the rural young people? This would be one of my questions. And if there is time permits, you can come on. Karen, would you like to add on some thoughts? Or?
Thank you very much, Bhumi. Those are that's useful and insightful observations. I wonder if we've just got a few minutes left, but Putti, would you like to give your thoughts, and then we'll ask Frida to give your thoughts on whether gender was at play in your settings, and did you consider it, and if you know, why would you include it or not include it in your analysis? So maybe we could start with Putti. And maybe all this presenters, you're welcome to turn your videos on.
Thank you, Karen. At the very beginning of our research, we also consider include both men and women. But then once we got the data from the prison authority, the number of eligible young prisoner, female, is much low. For example, like in one prison, a total of young prisoner is 500, but the number of young female prisoner is around 2 or 3 young prisoner. Then we discuss among our research team, and we consider this small number can be excluded from our study. But even though we still try to include them as much as possible, and we include them in our focus group discussion, a part of our qualitative study. Did it address your question, Karen?
Thanks, Puti. Yeah, that's helpful. So I guess in the setting where you were, there were very few young women. Frida, did you have any reflections on the different experiences for young men and women in your or gender diverse groups in your study?
There came gender issues came across quite strongly in the first phase of our research, where we did focus group discussions and interviews, where young males, for example, talked about masculinity norms and how they were asked to be like traditionally manly and like manly things, and how young women were expected to be more of a housewife type, and if they didn't like that, then most of them then moved more towards urban areas where they could be more free from the stereotypes and the roles. But we didn't include a gender perspective in the other phases, which would have obviously been super interesting. But then we would have maybe needed to include that aspect when we post this prompt statement, like, okay, do you think that this differs between groups and things like that? So there is possibility in our data to explore this further, but we haven't done it now.
Frida, you mentioned about mentor-centeredness. Would you like to expand on that a bit?
Yeah. What we found was that the participants talked a lot about like comparing their communities to the urban centers, and that like how much resources are like extracted from rural communities, and that there's only a focus on these bigger cities along the coast, and young people are just moving and the communities are dying, and that there need to be policies need to change, and that resources have to be distributed towards rural areas in order for them to be able to care for young people, and also to be attractive to them. So this is not something that we expect the communities themselves to do, but more of a broader issue that we can't just look at these communities in isolation from.
In other words, they were not pro-metro-centeredness. They are lobbying for rural resources, yeah? Yeah. Thank you. Karen, would you like to sum it up?
Yeah, so I just had a question for Chama. I just wondered, I think you and I both described that we felt we had increased quality of data or increased participation by young people as they had a greater familiarity with researchers. That meaning that a relationship is there. What do you think about ways that could be built on to increase the quality of data, and what do you think are the risks for, with the idea of traditional reductionist positivist research, where the researcher is not in relationship with the subjects of the research? Have you got any thoughts about that?
Well, I think my thoughts are that when you engage young people specifically and you make them comfortable, they tend to open up. I think we all are aware that usually adolescents tend to be very shy, and they tend not to trust adults especially. but I think you can improve, and because of the so many contextual ideals surrounding adolescent sexuality, it's also difficult for them to tell you what you need. I think from your study, you also mentioned that there is that social desirability to tell you what you actually want. And if you don't want them to use contraceptives, they'll tell you that they do not want. But the more you build a relationship with them, then they begin to open up about the issues that really affect them. And I think that's very crucial to getting good quality data, but that takes a lot of time. And I think that is why participatory research, or if you want to engage young people, it's not very ideal to just reach there and ask a lot of questions and then leave. It's really important to build a rapport.
Thank you. I think that's really useful. And I guess that the other thing that I found really interesting was ways that including people like policymakers beside young people, as Frida did, having policymakers present at the dissemination meetings and engaging with them, as Puti described. And yeah, I think trying to use the research as a tool for bringing change and greater peace or justice is really important. We're actually pretty much at the end of our time, and so I just wonder, Bhumi, do you have anything else you would like to add in before we close?
I'd like to really appreciate what you said, research as a tool for social transformation and bringing young people into the focus, because in most of the low middle income countries, the young people constitute about 50 to 60% of the population. And they have a say in deciding their future, not only in terms of mental health, ecology, environment. For example, the Greta Thunberg is a great, the voice of her is heard in the UN. So in that context, all the four people brought different methodologies to engage with young people to bring their voice in a greater forum. So this is of much importance in low middle income countries where young people are marginalized, like women. Also, they have poor access to literacy. For example, the current pandemic, 2/3 of the young people are left out of the education sector because of lack of access to technology. So these are all concerns. And these presenters and this symposium highlight this issue of involving young people and making their voice heard among the policymakers. Thanks to Karen for putting all the four different methodology from different settings. Thank you.
Well, I think that's us for today. And just a little plug, the HSR, there are a few other sessions happening today. And then we've got another round in this phase 2 of HSR 2020 happening on the 9th of December. So yeah, stay engaged, and really great to have those participants who were able to join today's session, and wishing you a happy evening, morning, night, day. Great to have you here, and thanks everyone for your participation and work.
In this juncture, I would like to thank the Global School of Health, UMIO, for bringing the diverse people from all over the world. Thanks, Karen. Thanks to the department in School of Global Health in UMIO. Thank you.
Thank you. Thanks, everyone. Bye.